In almost all patients, we have been able to take the relapsing MS and bring it under full control, stopping new relapses, stopping new enlarging lesions on MRI. We don't always do it in the first or the second therapy, but in almost all patients, by the time we get to the third or fourth therapy, we have found a therapy that is going to stop their relapses and stop their new lesions in MRI. And through that, we have converted relapsing MS in almost all patients to a fully manageable and controllable disease. In contrast, progressive MS, that gradual little by little decline in function, walking problems, bladder problems, coordination problems, cognition, we really have made very little inroads into slowing down the progression. When we can catch patients early in the progressive course, we do have therapies that can have a benefit, but later on in the disease course, we really aren't able to stop that gradual little by little decline. And so progressive MS represents a huge unmet need in the treatment options for multiple sclerosis.
The lines of therapy now are getting blurred in terms of first line, second line, highly effective, escalation. These are all terms that are thrown around, but they actually have very little meaning. One has a long conversation with the patient, and you pick the therapy that you think is best for them. In general, there's been a trend to shift towards higher efficacy therapies as long as they remain safe. But safety is always an ongoing issue, and safety concerns can develop years after a therapy is approved, and that would change the calculus of how you decide on what to treat someone with. It would be very nice if we had a biomarker that predicted treatment response. We don't have it yet. The best biomarker we have is actually looking for antibodies to JC virus as a predictor of risk of PML. But we don't have the metrics yet. We're looking at things like neurofilament light, which may be useful as a measure of therapeutic response, but that data is being accrued. MRI is helpful, but as I had mentioned earlier, we still don't have a way of quantitating it and saying, well, if you have this many lesions on this agent in 1 year, then you should switch. And we just don't have that data yet. The two main horizons that we're looking at now are neuroprotection, and that is protecting the brain and spinal cord from degeneration, and repair, as repairing the damaged nervous system. And we have strategies looking at both. The repair strategies are very exciting. They involve both potentially cellular replacement therapies, like stem cells, mesenchymal type stem cells, and also molecules that are being tested that would enhance endogenous repair within the damaged nervous system. Early phase work, but it's very, very exciting.